Okay, so it's 9 o'clock, first session of the morning. Appreciate everybody being here, and I'm glad to be here with you to talk about International Patient Summary. I'm going to talk about IPS on FHIR in particular, since this is a FHIR conference, and about how we can hopefully use IPS to open new horizons for a global clinical data exchange. And I am Rob Hausam. And this is just a little bit about me. I'm a family doctor, or GP, got a degree in electrical and computer engineering, and I work as a healthcare informatics consultant, and I'm one of the co-leads of the IPS project in HL7, and I'm also co-chair of HL7 work groups, Orders and Observations and Vocabulary, and I'm a co-lead on SNOMED on FHIR project. So those are a few things about me. Well, we've got quite a few slides, so I'm going to try to go through fairly quickly, but please feel free to interrupt or stop me, or if you have some particular question during the presentation, you can ask. Otherwise, we'll hopefully save a few minutes at the end for some questions. All right. I want to give a couple of acknowledgments to start. A couple of my colleagues, Giorgio Cangioli from Italy and Stephen Kay from the UK, have done a lot of work on a lot of these slides. They're definitely not all mine, but so I want to appreciate their contributions to this. Okay, so I'm going to start out and tell you a little bit about the IPX context and landscape, and we'll start. The notion of the concept of a patient summary. That's something that's not at all new, really. It's been around, really as long as we've been keeping records in some form or another. And so it's pretty ubiquitous. It's part of the fabric of healthcare. But everyone seems to have maybe their own idea, some different ideas about what exactly it is and what it is supposed to do. And we'll hopefully talk through a little bit of that, but you maybe have some questions about that. But we'll give it from the perspective of the work that we're doing right now and our take on what the patient summary is and we believe hopefully can do for us. Okay. So the patient summary is a pretty simple concept, but it comes with some baggage. So we'll try to talk a little bit about some of that. Okay. So we've been doing some work on this for quite a while, and particularly in the last decade or so. There's been quite a bit of rather intense work on various patient summary projects. And since we're in Europe, we'll be talking a fair bit about the European standards this morning. And we won't focus solely on that, of course, but there's a lot of activity in Europe and a lot of interest here. So in Europe, EPSOS, the cross-border pilot for patient summary, and actually, I'm not sure what EP Exchange is. I don't actually recall myself, but some other projects have been going on, and the eHealth Network guidelines were formulated in the 2013-2016 timeframe. And across the Atlantic, where I come from in the U.S., in 2010 we put together a EU-U.S. Memorandum of Understanding with the ONC in the United States. We had the standards and interoperability framework, and we had work on a variety of streams in that effort. And one of those was the Interpass projects, as it was known at that time, which was the early, basically the forerunner of the current IPS project. So if you've heard of Interpass, that's basically how it relates. And so there was, along with that, in 2015, a transatlantic eHealth, health IT cooperative roadmap, which enforced the idea of the IPS and why it was needed and of interest. Okay. So, and along with that, in the Joint Initiative Council, the JIC, in 2015, they started to work on the patient summary standard set, and it was basically to gather the efforts that are going on around the globe and kind of summarize what those were and give guidance on what might be useful standards for people to employ. So, but even prior to that, back in 2009 in ISO, there was a technical report and it talked about what a patient summary is, and it was defined basically as a health record extract comprising a standard collection of clinical and contextual information. That would be, both retrospective and current and and also potentially future, but the notion of it providing a snapshot in time of a subject of care's health information and their health care. And a couple of, the notion of extract and snapshot are kind of important, because there's been discussion about what is really a summary and what isn't it. And the notion of summarizing may not be that you simply abstract out of data and kind of recapsulate it. It may be taking our idea of it, or their idea of it at the time was taking the extract of data at a particular point in time, and that's the notion of summary that we're talking about primarily. Excuse me. So it is, as we just said, the health record extract, and it's also international. It's emphasizing the need to provide generic solutions for global applications beyond, and that's beyond any particular region or country. And country is sort of our big use case, and certainly that applies, I think, in Europe, where we have a lot of countries, although all part of the, or at least many of them part of the European Union, not all, of course, but there's national boundaries that are involved there, and also in, as I come from the U.S. to here, I'm involved in crossing boundaries for needing for healthcare, and actually it turns out that just ironically, 4 weeks ago today, I was in Warsaw, Poland at the HL7 IHIC meeting, and I had a little accident in the evening, Wednesday evening, off of a scooter, and you might see the result of that there. But anyway, it's healing up, but I had a pretty nasty blow to the head, and I ended up having to experience the Polish healthcare system, and it would have been kind of nice to have an IPS with me, or to be able to get one back from there. But they did a good job, but those kind of things do happen very unexpectedly. So, yeah. It's a good question. So the question is, who's the source of this? And that's a very important question, and obviously it has to be answered. I will say that we're basically taking a phased approach to this, and we're not answering that question yet. We're giving some ideas of what the source may be, and we want, that's part of the challenge at the end of this talk, is basically to help us flesh this out and decide. In Europe, there's a pretty strong cross-border services infrastructure. Many other places there may not be such a thing at all. And honestly, I think that particularly in the FHIR world, I'm expecting this to be probably the most common medium of exchange. If I had that IPS with me on my iPhone, I could have handed it off to the Polish doctors, and that might have been a good thing to do. But so I'm expecting that that'll be a very common thing. So we need to flesh that out. So right now we're building the standard for how the data needs to be exchanged, and we're purposely not saying it's going to be one way or the other at this point, but we obviously have to answer that question. So more about European participation in CEN. CEN TC251 is a regional SDO, and this talks about sort of the woes of CEN at that point. Didn't have any real funding to work on this, and kind of felt left behind, I guess, a little bit. But they presented a proposal to the eHealth network and secured some funding, and work on the IPS on the CEN side started in September 2016, and that's about the time we reinvigorated the project as the IPS. And so the tactical aim was participation, and so the eHealth network guidelines for the patient summary data set were formal requirements for CEN, and they fit in with these other projects I mentioned, and helping to build a foundation which we could have some shared work, and basically a starting point for dialogue and cooperating. And with that, those things coming together, on the HL7 side and the CEN side, that became the IPS project, which is we're currently actively working on together, having a shared vision. So it's been a good collaboration. And when we started out with that, we talked a little bit about what is our vision and what's our scope. The vision is at least certainly the initial vision was to collaborate on a single common international patient summary specification, again, readily usable by all clinicians, with the primary purpose being cross-border unscheduled care of a patient, just like what I had in Poland, basically. But we'll see in a little bit that we're not limiting ourselves to that, but that's where it started. The scope was basically to focus on a minimal and non-exhaustive summary and keep it specialty agnostic and condition independent, not tied to any particular thing. It's not a diabetes summary. It's not a summary for cancer treatment. It's not any of those kinds of things. It's for for general care, but it's data that should be clinically relevant. We don't need to include everything, that's particularly things that are maybe outdated or whatever reason it might not be so relevant for current care. So, all right, so we developed some principles which were that they should be implementable, applicable for global use, extensible and open, and sustainable. And we'll see more about this, about the 4 deliverables. Keep track of my time here, but so I will show this. This is the only slide I have on CDA, which is a FHIR audience today. But we did start and we developed a CDA specification, an HL7 CDA R2 standard, and we got that published, and then we started working, heavily on the FHIR standard, which I'll talk about this more, but we'll be soon to publish. So, but the notion is that there's a lot of activity, out there in CDA still, and so we're not necessarily saying this has to be FHIR at this point. Folks who need to use CDA can, do have the opportunity to do that as well. Yeah. Well, I would say the answer basically was how does it compare with the CCDA and are those templates used? The answer is they're not directly used, but they're certainly used to inspire the work, and so are some of the other efforts that are out there. But as I'm sure most of you may know, but CCDA is a United States realm specification, and therefore it has some, some peculiarities that are specific to the United States, and it's definitely definitely informed our work, but we didn't base our work directly upon it, partly in large part for that reason. Okay. All right, so then we also have as I said, the FHIR IPS implementation guide, and it's based, at this point, we started out on STU3 a while back, but we moved pretty quickly as we were starting to approach R4 to an R4 based specification, and that's where it is now. We have gone through 3 ballots in May and September of last year, and also September again of this year. The continuous integration build is out there, and soon, very soon, within the next month or 2 months, we should have a published standard for trial use specification of the FHIR IPS IG. We had actually kind of hoped we might have it by the time of this meeting, but we're not quite there yet, but we're closing on it pretty rapidly, so that's what we expect. Okay. So this is a bigger picture of that 4 IPS project deliverables there, and actually I don't have a pointer handy, but probably could do it here if I need to. But we see the 2 SEND standards here, and we'll talk maybe a little bit more about those. And then we have the FHIR standards, the HL7 standards at the bottom, the FHIR and the CDA. And so basically, SEN builds on top of the HL7 standards for their work, and then we'll see there's some other people getting into the game too here just recently. So that's a diagram of kind of how we're organizing all of this. All right, so with those project deliverables, basically we have the global standards at the bottom, which you can see, and we have the EU scope is specified in the 17288 standard, which is the technical specification of the IPS for Europe, and providing guidance for the EU. And then the basically EU standard, which also has global aspirations, the 17269, we'll talk about a little bit more, is more of the abstract model, and the patient summary guidelines for eHealth Network, kind of work on top of that. So that's kind of how this all lays out. All right. So let's go through a little bit more about the data set itself, the notion of it being a minimal data set, non-exhaustive, and we'll talk a little bit more about what these mean here in a second, especially agnostic and condition independent, but still clinically relevant. So that's what we strove for, or are striving for, I should say. And the principles of being implementable, applicable for global use, extensible and open, and sustainable. Okay. So drilling in a little bit more on those, minimal is the notion basically of being a summary, like I mentioned before. Need to be concise. It sort of at least alludes to the existence of this core data set of items that all health professionals, would be able to use. Again, that's going to vary depending on exactly what specialty you have and all of those things, but there is a core set of information that should be useful very, very broadly. So it's non-exhaustive, meaning that the data set isn't closed. It's likely to be extended in the future, not just in terms of requirements, but also just experience of use, pragmatic needs. People are going to find additional things that they're going to want, and that's what we try to plan for that as we develop the standard. But right now, that kind of data is out of scope until we have further review. Okay. So especially agnostic and condition independent basically just means that we're providing at least a starter set of data to help inform a person's treatment. It's irrespective of what condition it is or which particular patient or what particular doctor, like that, who's tried to manage the care. So implementable is talking about basically want to promote evolution and convergence of standards, existing standards where we can use them, rely on solutions that are already implemented or are ready to be implemented, and consider new or additional solutions as they become available. So be flexible and open and able to be useful in the real world. So. And for the global use, being applicable for that, we're basically saying we want to have our goal that we strive for is global accessibility of the standards for free, free for at least for use at the point of patient care, and that includes both our information model standards, including FHIR and CDA, as well as the terminology standards that we strive for. In some cases, we have some issues with that because not all the standards are that way at this point, and that can be sometimes a barrier, and we have to deal with that. Looking for a core set of globally accessible and broadly usable terminologies, and we're not including local solutions that aren't available other places, and we do include free text because that's sort of a common denominator. Now, it may not work across language barriers, of course, but it still at least is a baseline that everyone can use in one way or another. So, but we try to emphasize structured codes as much and wherever that's possible. So again, we're extensible and open. We try to be open to new use cases and various other kinds of emerging solutions or improvements. And IDMP was listed there as one potential for medications. So as it comes along, that may be something we may be able to look at down the road. So sustainable, just talking about maintenance and updating and ensuring clinical validity and building in ideas for how to do that. We're not really, in the base standard, we're not necessarily specifying exactly how that needs to all be done, but we're acknowledging the fact that it is needed, and folks will have to be dealing with that. All right. This just shows a basic list of the sections that we have outlined. This would apply to both the CDA and the FHIR implementations, particularly it was in the document paradigm. So there's some header information, basically, who's the subject, author, tester, custodian, and then the required sections, kind of, the big three. What are your medications? What are your allergies? What are your problems on your problem list? Those we think everybody needs, for pretty much any kind of care. And then there's some recommended ones. You may want to know immunization status and what procedures the patient's had, and any devices, particularly implanted devices that are on a patient, and some relevant diagnostic results. And then there's also sections that may or may not be particularly useful in a particular case, optional. So there's kind of a limited use of vital signs in a patient summary, I think, but there may be some use, and there's some specifications that do recommend some basic vital sign information, but it kind of gets out of date really quick, but it is an optional section. Got past history, pregnancy, social history, functional status, plan of care, advanced directives. Those are the ones we've identified. Some people have asked for some other ones, and we're open to that, but looking for ones that would be, generally have some broad utility. Okay. So the first iteration, as I mentioned earlier, was basically focusing on use for unscheduled cross-border care. And cross-border is, again, international, national boundaries, but it can also be other kinds of borders. There's, borders within nations as well. And of course, in the United States, we have, 50 states, and they have a lot of differences between them, a lot of things, and many of the other countries have similar kinds of situations. So those kind of borders too, and borders between health systems, and we're basically crossing all kinds, potentially crossing all kinds of borders to be able to transfer care from one healthcare setting to another and make it usable. That's the idea. So, so this is the baseline that we can use for, and we can also build out for scheduled care and other kinds of things, as people find the needs for that. All right. So there's kind of a progressive approach. I'll go through these slides kind of quickly, but today, it's kind of focused mostly on the cross-border unscheduled care, assuming we're likely to be talking about adult patients, maybe traveling for pleasure or business, that sort of thing. But that's the initial idea. But if we move a little bit beyond that, as things mature, then we, be looking at, enlarging the stakeholder community and different, looking at different capacities and potentials for gain, and kind of broadening it out for there. And as we get more acceptance and adoption, again, we'll just continue that process basically. Okay. So extending the use case might involve something like, it's talking about the adult person has a health need while in a foreign country, like I said, like I had 4 weeks ago. Demand for care, then there's contact, and it could be unplanned or unscheduled, but again, we're talking about no prior record, and the request is made for the patient summary, and it's received at the point of care and maybe integrated into the local system. But around that, we're dealing with, we've got the GDPR for, basically data security, and that's obviously important in Europe, and general notions of it in other places as well. But we're interested in care for all ages and for dealing with local needs as well, and basically just kind of building out from that base use case. All right. So this slide just has some examples of how data might get added. I'm not going to go through the details of it here, but you start with some basic data, and then you add some additional data elements, and you expand from there. Okay. But important fact to keep in mind is that we're basically scoping it. The IPS, the International Patient Summary, it's not the EHR. It's not all of the data. We're not expecting anyone to transfer or carry all of that. I mean, a lot of that has, again, it has its own baggage, I think. Many of us, I think, probably know how hard it is to sort out the important data out of the mass of data that sometimes the EHR contains, and find out what is, what's really relevant. So we're trying to focus on that more, relevant, more current set. It's not the EHR. Okay. But it can be the basis for, future exchange formats, including for example, the European EHR exchange format, or similar, other kinds of efforts that would be similar globally. So we can build out from the notion of the IPS and reuse those building blocks basically. So let's see. So we basically start. We have we're looking toward a library of reusable, common core templates or building blocks, whatever you want to call them, but making that extensible. So you might add these extensions, and this is showing a yellow card for vaccinations, and we did some work on that about a year ago with the EU MODEX exercise in Bucharest. They used a mobile field hospital. Encounter reports were exchanged via FHIR IPS resources, and it was part of the Trillium 2 work, and that was a pretty successful demonstration. It was a good thing. And so, kind of coming back again to the fundamentals here. We got the IPS is a document, and that's where we start. And the current intended use is as a document, but expected use in the future will include, being used not only as a document but also as a library, reusable data components. So that's where we're headed. All right, so this just talks about sort of a collaboration framework, and I'm not going to go into really details of that. You can look at that later if you want to do that. Let's move on. This I also will not go into detail, but it shows a model of kind of how this all fits together, and I'm sure you can't read it from there very, very well, but you can look at that later as well. Okay, so we're hoping that IPS will help to establish some best practice, and our collaboration between HL7 and SEN has worked really well over the last, we basically, almost published 4 specifications in just over 2 years, and we hopefully we'll extend that, and we'll continue to have more. So the next one that sort of gets added to the mix is on the terminology side with the SNOMED CT free subset, which was on the HL7 side of things was basically inspired by the IPS project. We were basically the reference use case for the HL7 submission for the SNOMED free set. And originally, SNOMED was offering free sets of concepts to various organizations, but then they decided to go ahead and merge that into a single global patient set, which includes all of the basic free set offerings, and so the IPS set is a part of that. It's a larger set, and so now we are in the process of incorporating that into the IPS specification because it's just been newly released in September, officially available, and we need to update the IPS to be able to include that and allow people to make use of that where in non-member countries. And looks like I'm running pretty short on my time here. Let's see, I didn't mean to do that. Okay. So anyway, the family's growing, and we've added 2 new things, work streams just recently. IHE has gotten into the mix with a new IPS profile, and just actually it was 2 weeks ago at the ISO meeting in South Korea, basically approved the fast track ballot for the ISO 27269 specification, which is basically taking the SEN work on 17269 and making it international. So with that, we now have the 7 IPS project products, including the SNOMED free set and the HL7 and IHE. So we're adding to the mix. All right, so moving things forward a bit. This is timelines. I won't go into a lot of detail here, but again, we approved the publication. We published the CDA in 2018 in October, and we passed our 3rd ballot of the FHIR IG in September, and we're going to be publishing by the end of the year or the first part of next year. Definitely the plan is before the HL7 work group meeting in Sydney, and we expect to have it published by that time. Okay. And SEN is also moving ahead with their specifications. Well, one other thing that we're working on, we definitely worked on in this last ballot, was aligning with Argonaut Specifications, because that has a lot of potential for dealing with large-scale implementations. And there was a comparison done between the existing versions of the IPS and the Argonaut, and we incorporated feedback from that in our recent ballot, and we will in our publication as well. And so I'd love to hear any more takes that anyone has on that. But Argonaut, again, is in U.S. core, which is sort of the FHIR version of it is U.S. specific, but we're trying to align again with that as much as possible. Any question? Yeah, well, I mean, that's a good question, and I'm not even sure we've done it as well as we should, but, look at the things that are both relatively straightforward to do and to align. If there's obviously just sort of more or less arbitrary differences, we'll try to eliminate those. One area which I think it's the next slide, this answers partly that. Terminology we don't expect to fully align because where U.S. specific terminologies like RX norm or specified for medications and things like that, we're not going to suggest that everyone use that globally, but that is a problem area. I kind of wish we could do that, but get everybody on one medication terminology, but that's a future goal. But the IPS is going to stay with the I. It's going to stay international, and so we try to align as much as we can, but we don't expect to get complete alignment. So, all right. So current state of things is, we've got the information models and then the implementations on top, and they're kind of, one informs the other, but they're not necessarily really connected, tied together as tightly as they probably should be. And so we're working on tightening that up and building out FHIR logical models in order to basically have a logical model that's the basis for all of the specifications, including the send work in HL7 and both streams in HL7, the CDA and FHIR. So that's a direction where we're headed. And this is a little bit more on the send 17269, which forms that data set, that logical model specification, which now is going to ISO. Future development, we're looking for identifying new or missing use cases and content. Expect to publish new versions, potentially both CDA and FHIR. I expect FHIR is going to be the most widely used, but again, there's a lot of CDA out there still, so we're trying to do both. And we need to figure out how to sustain and support the effort going forward, and focus on encourage implementations in a variety of places. And so this is a nice little graphic that I don't know if those of you who might know Christian Hay from Switzerland and GS1, but his group put this together, and I think it's a great kind of picture of how you build the IPS and all the different, with all the different component parts that all working together. So I like that. So we've been hearing about some initiatives around the world, and just a few of those. Argentina has done some work, and we're going to see quickly at the end here a little viewer that they've worked on, and they've gotten some good work done there. And Norway's looking at this, and Italian patient summary, and there's quite a bit of interest we're hearing about in Canada, particularly in Ontario, and also in the UK, both on the SEN and the FHIR side. The Austrian patient summary has agreed to be based on IPS, and the HDSDI is continuing to talk about it and working with 17269 data set. And we're also talking to Asia about it, and hopefully get some traction there. I was able to speak about it to the South Korean Medical Informatics Society a couple of weeks ago, and that was good. And we've got the IPS community of practice I want to make sure everyone's aware of. So we've created this on the FHIR Zulip chat. It's not limited to FHIR. It includes all aspects of IPS, but you want to get the whole community together, and this is a good, fairly high traffic place to be able to do that. But it's open to any and all discussions, so please check that out and provide your comments there. And let's build some discussion. Okay. And I wanted to show, I think we got a couple of minutes here. Yeah, take a couple, and then maybe some time for questions at the end. And the folks in Argentina, Diego Kamenker and Fernando Campos, worked on an IPS viewer, which I thought I would show. This is just a little shot of what it looks like, but we can switch over and actually take a look at it. And let's see. That should have, let me go ahead and copy. I got a JSON instance of IPS here, and I'm going to copy it and paste it into the viewer. Okay, just scroll back up to the top. I guess not that it really matters, but all right. So if I hit the View IPS button here, then I get a rendering of at least the first basic parts, the high-level stuff of the IPS instance. So allergies and tolerances, showing out to medication, penicillin allergy in this case, with high criticality. Got a list of problems, in this case menopausal flushing, and some current medications. So again, a nice little view of what this might look like. And if we can switch it to a text mode here and see all that. So that's just a little simple example of a working implementation that uses IPS. And there's a lot more that we're working on, and a lot more that can be done, obviously. Let me get back to my slides here real quick. That's the output you saw. And we're working towards an IPS ecosystem with all of this, talking how we create it, how we govern it, how we align it. And with that, we've got multiple actors. We've got, got patients at the top, clinicians at, down here at the bottom. The SDOs are involved. Various deployers or implementers, policymakers, vendors are all involved in this. And on the product side, we've got basically we can start with the computer logical models, and particularly once we have that all in place. Educational material, the APIs, system functional models, guidelines, the validators and terminologies, all those things that go into making this work. So we would like to hear from you about your interest and your efforts, and any comments, questions about the IPS. And the challenge for the group and for all of us is the IPS, let's make it real. And are you ready to do that? So that's the end of my slides. So thanks for listening, and let's take questions if there's still some time to do that.